My total, yeah, okay, so just heads up, we are recording this, so if you speak up, your voice might be recorded, but we'll try to make it so only the presenter's face is shown. But yeah, without further ado, it's my total honor and privilege to welcome Dr. Lowan Stewart here to have a talk for us about ketamine for alcohol addiction and other addictions. Lowan is co-founder of Nordic Psychedelic Science, which we here in Bergen is a node of. He has been an emergency physician for several 2 decades now, working in the United States and also working to implement this subspecialty in Norway. He has founded a ketamine clinic in USA and also here in Norway, Axon, now Awaken Clinics. He has done thousands of treatments with ketamine for depression, and is also now, the last couple of years, done treatments for addictions. I'm myself so excited to hear Lowan talk about his work in ketamine and everything else. So without further ado, and I welcome Lowan Stewart to the stage.
Great, thank you very much. Let me just share my screen here. Okay. All right. Yeah. Excellent. So yeah, thank you very much for inviting me. Nice to see. I see some names out there that I recognize, and very excited that to see the rest of you that that are joining this. There are incredible things happening in the field of psychedelic science. This is really the future. I think the future of mental health, and it's and also the future of our the science of studying consciousness as well. So incredible time to be learning more about things in this space. And I'm very grateful for the opportunity to be alive during this time and to be able to work with this kind of stuff. So yeah, a little more about myself. So I'm primarily working with Awaken right now. I'm also the medical advisor to our psychedelic research unit at Sykehuset Østfold, Psykforsk, where we've got a study on MDMA for depression, an upcoming study with psilocybin for depression with Compass, and then the phase 3 trial with MAPS for MDMA for PTSD. And we also have a ketamine unit there that primarily treating depression in the public system. So yeah, my background primarily, I've worked most of my life in the emergency department, and you know, in the emergency department, over several decades, I've seen hundreds of people die from substance use disorders, primarily alcohol, tobacco, opiates, and you know, I've had the experience of saving a lot of people's lives, but it's often, you know, the same person who has come back again and again due to the lack of really effective treatments for people with severe substance use disorders. So it's really exciting to be able to talk about something new in this space. mostly, many of you have probably heard about using ketamine for the treatment of depression. And, depression and addiction share a lot of common fundamentals. One being stuck in negative patterns of thinking, feeling, behavior, and being stuck in those patterns despite negative consequences. And they also share many people with depression or addiction, share a common origin in adverse childhood experiences, stressful experiences early on in life. So I'd like to start off by reading a quote from the American poet Edgar Allan Poe, who suffered from and died of alcohol use disorder. He said, "It has not been in the pursuit of pleasure that I have periled life and reputation and reason. It has been the desperate attempt to escape from torturing memories, from a sense of insupportable loneliness and a dread of some strange impending doom." So I think that that captures the experience of many people that suffer from addiction. So substance use disorders are a huge cause of global morbidity and mortality. Alcohol use is actually, right now, it's the 5th leading cause of disability adjusted life years that are lost in the world. And in middle income countries, it's one of the leading causes of this morbidity and mortality. And despite there being a lot of treatments, psychotherapies and drug treatments for substance use disorders, unfortunately, the treatments that we have are not effective for everybody, and there's a lot of room for improvement. So that gets to ketamine. So ketamine is actually a naturally occurring substance. This was just found out a few years ago, but there's a fungus called Piconia chlamydia, and ketamine is produced by this fungus. It lives in the roots of plants, and it's one of the hypotheses is that the fungus uses it to paralyze nematodes or parasites that are parasitic on the plant. So ketamine is a plant medicine, for anybody wondering. It was first synthesized by humans in 1962, tested on prisoners in 1964 in the US. That's how we tested new medicines back in those days. And it was synthesized as a replacement of the anesthetic PCP, phenylcyclidine, angel dust. That was actually a relatively good anesthetic, but it had a lot of side effects. So it was approved in 1970 in Norway, 1973, as an anesthetic, and gained widespread use during the Vietnam War for anesthesia and pain control. And today is one of the most widely used medicines in the world. It's on the WHO list of essential medicines. It's a NMDA receptor antagonist, which separates it from many of the other psychedelics. So it does not directly stimulate the serotonin receptor. So as I said, ketamine was, for most people think of it as a treatment for depression when we're talking about anything other than anesthesia. In 2000, evidence-based, sort of modern evidence-based medicine work with ketamine started in the United States with ketamine for depression. And over the subsequent decade, there were many more trials, and there are now consensus guidelines in the US and Canada, international guidelines supporting the use for ketamine for depression. In Norway, I'll just go briefly through sort of the story, what happened here in terms of using it off-label in the field of mental health. So after I started a clinic in the United States, I came here and I talked to Ulrik Malt, the head of the Norwegian Psychiatric Association. I talked to the health directorate. I gave lectures at various universities, and I said, okay, let's set up a committee. Let's put ketamine for depression into the public health system. And there was very little interest from anybody. So I just opened the clinic, started treating people privately. The Psychiatric Association turned me into the medical board, which supported the work that we did completely. And several years later, we got the public program started at Sykehuset Østfold. We've treated about 150 people in the public unit, and right now there's many other public units opening all over Norway. We are currently working to get some national guidelines, this thing, ny metoder, there's something called the Beslutningsforum, where if they can support it, then they will support these ketamine units financially, which will be important in terms of increasing people's access to the treatment. So there was a interesting, it's kind of, things have changed quite a bit in the last 5 years with psychedelics in general, but with ketamine specifically. In the beginning, as I said, I was turned into the medical board by Ulrik Malt, and then just a couple of weeks ago, Lars Lien, the new leader of the Norwegian Psychiatric Association, published this article in Aftenposten saying, why aren't we giving access to ketamine to these patients? So as Max Planck said, science advances one death at a time. Ulrik Malt is not dead, but he retired, and there's a sea change of more people who are reading the data and more open to novel treatments in mental health. So that gets us to substance use disorders, using ketamine to treat addiction. So most people find this concept somewhat, inherently paradoxical. Isn't ketamine, Special K, that's a horse tranquilizer, that's that stuff you could take at a rave. How could you use a drug to treat a drug addiction? It seems like that doesn't make any sense. And so just, one reflection on that is that this whole concept that exists, that there's a semantic idea that there are drugs and then there are medicines, and that has no basis in scientific fact at all. This is a cultural distinction. So, Paracelsus, the founder of toxicology, said, the dose makes the poison. But it's not just the dose. So water, if you have enough water, you could die, but it's not poisonous. But it's also the context, how things are used. We use morphine to treat, morphine is diamorphine, or morphine is basically heroin. Heroin is diamorphine, and we use heroin in the UK, just straight up heroin, not morphine, to treat, broken bones. If your grandma has a hip fracture, we give her morphine. I have cocaine in my medical bag. We use it for nosebleeds. We give people amphetamines for ADHD. And even alcohol itself is actually the antidote to ethylene glycol poisoning. So it's about the context in which these medicines are used, and other factors, which I'll discuss a little more later. So the early history of using ketamine for alcohol use disorder actually goes way back to the 1950s. This is Humphrey Osmond, an English psychiatrist who was working in Canada, in Saskatchewan. He had a addiction center there, and he had noticed that people who were going through delirium tremens, so when they were withdrawing from alcohol and they went through this delirium where you could hallucinate and have this very uncomfortable withdrawal syndrome, it appeared that people who had that actually were more likely to be abstinent compared to the people that didn't go through delirium when they were withdrawing from alcohol. And around that time, there had just been a new medicine called LSD invented, and it appeared to cause something like a delirium. So it caused this psychotic-like state. And he thought, well, maybe if I could induce this delirium in people with alcohol addiction, that would kind of scare them straight, scare the shit out of them, and they would become more likely to be abstinent. So he actually gave over 2,000 people LSD for alcohol use disorder, and reported pretty good outcomes. About 45% of them were abstinent a year after the treatment. What he did find is that it wasn't the terrible bad experience that was correlated to a positive outcome, but in fact, it was the transformative, positive, meaningful experiences that many people had in this psychedelic state that was correlated to positive change in their lives. And incidentally, Humphrey Osmond was the psychiatrist who invented the word psychedelic, meaning mind manifesting, in a letter to Aldous Huxley. So I'm going to go through some of the studies here that have been done on using ketamine for substance use disorders. What happened, so after the 1950s, there was tons of work using other psychedelics for addiction. But of course, that was all shut down in 1970. So Nixon shut down psychedelics in the US, and then the United Nations, everywhere else, scientific research shut down as well. But remember, 1970 was the exact same year ketamine was approved as a medicine. So all these researchers that had been using other psychedelics now only had one legal psychedelic to use. So it was used in what we call psycholytic therapy in the 70s and 80s in Central and South America and Iran. And then in the 80s, a Russian psychiatrist started using it. He had a addiction unit in St. Petersburg and started treating people with ketamine and psychoanalytic psychotherapy. And he also started kind of first in this way of trying to scare people straight. So so he actually gave them amphetamines, and in addition to the ketamine in the beginning. But so he had the first report. He treated a couple hundred people and showed that a single dose of ketamine versus the standard treatment had a 1-year abstinence of 66%, which is quite good relative to other treatments that we have available now. Jump ahead, more recently in 2019, there was a very interesting study done in the UK. Now, this was with people with, you would say, moderate alcohol use disorder, mild to moderate. These were actually just college students who were binge drinking. So they're, what do you call it? Skadli bruk of alcohol, but not heavy drinkers. In this study, what they did is they, instead of just giving ketamine, they had several arms. So they had ketamine, and then they had another group where they got ketamine after activating the memory, the maladaptive reward memory of the alcohol. So they would get people they would activate that memory, like, oh yeah, I'm going to have this nice, excellent, refreshing beer. And then they got the ketamine. And they found that the group that had that memory activated had significantly decreased alcohol use compared to just the ketamine group 6 months later. And so about half the number of units 6 months after this treatment. So pretty significant and durable findings. Dakwar is a psychiatrist in Colombia. He's done a lot of work on ketamine for addiction. And he did a study showing that ketamine plus mindfulness-based relapse prevention for 5 weeks had a 6-month abstinence of 75% versus 27% in the placebo group. So really impressive results. And the largest study that's been done to date was done by my colleagues at the University of Exeter and Awaken. So this was 96 patients with severe alcohol use disorder. These were people that were drinking on the average more than 6 units per day. And they, in the beginning of this study, they were drinking 98% of the days. So, 98 days out of 100, they were drinking. And what they found was that at 6 months after the treatment, which was 3 ketamine treatments done over 3 weeks, combined with a mindfulness-based relapse prevention, 6 months later after the treatment, 86% days abstinent. So really profound and durable improvement. And they were 2.5 times less likely to relapse than the placebo group. Another really exciting thing about this trial was they had measurements of liver function tests. So the liver function in people with alcohol addiction is a good predictor of their mortality, their risk of death. And the liver function tests, when they're very high at the left side of the screen at the start, you see in the placebo group they go down, but then they go and they went down because everybody had to be abstinent at the beginning of the study, but then they went back up. And in the care group, the liver function remained good, better. And what this means is that if we were to take their liver function, their chance of dying in the next year was 1/10 of what it was before the treatment. And this is, 6 months later. So this is what we call a, clinically relevant or a patient-oriented outcome. I mean, it's really important that you're not drinking or you're drinking less. Yes, that's a good outcome, but not dying is a even better outcome. There's a lot of other comorbidities of alcohol use disorder too. It's not just dying from the alcoholism, but there's, it affects many other aspects of your health and other diseases that you might have. Ketamine has been studied with opiates and opioids. So Krupitsky in St. Petersburg also treated people with heroin addiction. His initial study showed a 2-year abstinence of 17%, which was better than placebo. But he did another study. Oh, there we go. He did another study where he showed if you repeat the ketamine doses plus the psychotherapy that he was doing, a 1-year abstinence of 50%. And for people with heroin addiction, this is a really that's an impressive number from a treatment that only 3 doses of ketamine and psychotherapy. Dakwar at Columbia has done 3 trials on ketamine for cocaine use disorder. And it's notable to say that there are no current approved pharmacotherapies for stimulant use disorders. So this is a difficult to treat population. And he showed that the largest trial that he did in 2019 showed a 5-week abstinence of 48%. People were 50% less likely to relapse, and a significant reduction in craving scores. There's been a small pilot with cannabis. This was only 8 people who were on the average smoking 5 out of 7 days. And after a single dose of ketamine, they were down to 0.5 days per week at 6 weeks. So there's some indication that it could be useful for cannabis as well. And nicotine has not yet been studied in humans, but in rats, it shows decreased nicotine self-administration after ketamine. Much more significant in male rats, which is interesting. We don't see a difference in males and females in human studies. But it's an interesting, I think preclinical work is interesting because, it does tell us that there's a lot of neurobiology here. It's not only the psychedelic effects or the, phenomenology of these experiences that that are causing the improvements in addiction, unless the rats are also experiencing amazing, profound, meaningful psychedelic experiences, which may be the case. So I'll go a little bit into the potential mechanisms here. Ketamine is a really weird drug. So, when it was synthesized, it didn't fit any other drug that we had. So Edward Domino, his wife, came up with the word dissociative anesthetic. And it was called dissociative because it has this unique property of feeling disconnected or disembodied, detaching from your body. At a very low dose, it's just pain medicine, so it has good analgesic effects. At a very high dose, we call it a dissociative anesthetic, meaning we can do surgery on you and you don't remember it. We don't really know what happens during anesthesia, but at least you don't respond to the surgery and you don't remember the surgery. And then the middle dose is the psychoactive range, where there's these powerful psychoactive effects, psychedelic effects, and that's where the most positive therapeutic effects are seen in all the studies on mental health disorders and addiction. It's actually a relatively low dose at this psychoactive effect, and the phenomenology of the ketamine experience is very difficult to describe, but it overlaps somewhat with classic psychedelics, with altered sensations, altered perception, altered cognition, alterations in your sense of space and time, synesthesia, and then this relatively unique property of being dissociated from your body, which is similar to what people can experience with classic psychedelics, like ego dissolution, transpersonal, transcendental experiences where the boundary of your conscious awareness seems to dissipate. So it's, I like to think of it as less of like an ego death and more of an expansion of the boundary of your conscious awareness. So people are conscious, but there seems to be less of a boundary between you and everything else, the universe, things beyond yourself. And it also creates like an observer state, so where you can kind of see, similar to what people experience in mindfulness practices or meditation, where you're kind of stepping back and can see your thoughts and feelings and your own ego from a little bit of perspective. To start from the very bottom level up, ketamine is an NMDA receptor antagonist. It antagonizes the GABAergic interneurons, which are inhibitory to the cortical glutamatergic neurons. So it inhibits the inhibitors, so then you have increased glutamate release, which then preferentially stimulates the AMPA receptor and then increases brain-derived neurotropic factor. So BDNF then stimulates the process of neuroplasticity, so increased dendritic branching, increased synaptic spines. So basically replenishing, giving kind of root stimulator to the brain. So you actually grow new connections. And this here is a picture of a rat that got ketamine, and 24 hours later, you actually see new synaptic spine formations. And what that means is that this reverses the effects of chronic stress on the brain. So chronic stress states, whether it's depression, whether it's anxiety disorders, PTSD, or addiction, cause neuronal atrophy. So you actually get decreased dendrites, decreased communication between the brain cells, sort of a thinning, a pairing, and this. So the stimulation of neuroplasticity increases how it's sort of experienced by people is increased flexibility, decreased cognitive rigidity, and more flexibility in your thoughts, your feelings, your behavior. So people with chronic stress states are often very rigid. This is what I do, this habit, I do it every day, and they're very stuck in these patterns. So as we go up a bit to the level of electrical networks, there's some electrical networks that are sort of normalized during the ketamine experience. So one is the decreased prefrontal cortex activity that people have with chronic stress and addiction is normalized. So there's increased executive function, increased prefrontal cortex activity. And the other one is the default mode network, which is talked a lot about in psychedelic literature. And this is your sort of wandering mind, the part or the network that's active when you're thinking about the future, thinking about the past, gruebling, rumination, where you're just sort of stuck in a thought pattern instead of doing something, just thinking about it again and again. And the opposite of that is flow. So tilstedevaro, presence, just being in the moment, doing something. So when you're, riding a bike really fast or on skis, you're not thinking about the future. You're not thinking about the past. You're not anxious. You're not depressed. You're just here now. And ketamine kind of balances that and actually allows people to more easily come into a flow state or a more mindful state. Another network that's involved is called the negative reward network. And this is in the lateral habenula. There's this part of your brain that its sole function is to punish you. So it sends out projections to serotonergic and dopaminergic areas to, that it's hopeless, helpless, you're, low self-image. So this is the opposite of the reward network that is stimulated when you take a drug or you eat food or you have sex and you get a little dopamine boost. So this is, we're animals, we go out into the woods, we try to find food, no food. We need to be punished and feel bad, so we adapt our behavior and go to a different forest next time. But in people's brains who, when the brain is developing, if there is insecurity, if there's a lot of trauma, you don't know when it's coming, you got an alcoholic father, you don't know when he's going to hit you, instead of turning on and off, it's just kind of always on. So it's almost like the thermostat is set too cold. And ketamine normalizes that. It's a NMDA receptor dependent area. There is some evidence that ketamine can decrease hypertrophy in the nucleus accumbens, and this is a part of the brain that's involved in the sort of the driving of craving in alcohol addiction, and there's sort of a decreased responsiveness to dopamine, and then it becomes hypertrophied. And there's some evidence that ketamine actually shrinks that. And there was recently a study in Nature that was quite interesting. You know, because ketamine can be, there are people that you know, have ketamine use disorder, but it's actually relatively rare. And this group found that one of the reasons is that, so ketamine triggers the reward network, but then because it's an NMDA receptor antagonist, it actually blocks the sort of learning of that maladaptive reward. So you get a brief dopamine release, but then it's shut down very quickly by the ketamine itself. So it decreases the addiction liability, which is helpful since we're using it to treat addiction. Finally, I'll mention the psychological therapeutic aspect of so you know, there's all these neurobiological effects that are involved, but the experience itself can be profound, meaningful, and in of itself can have really therapeutic effects in people with addiction. There's something we call the overview effect, which comes from astronauts looking down at space, looking down at Earth for the first time. And they get this, you know, by having some perspective, that observer state, by stepping back and out of yourself, you look down and you see that, yes, there's all kinds of shit going down on the world. There's war, there's politics, there's suffering. But in the big picture, with all these other planets and galaxies, and it's okay. So people can have this kind of sense of, one, a connection to something larger than themselves and all the problems that they're stuck in, and two, a sense of equanimity, you know, almost this Buddhist feeling of, you know, yes, there are things that are bad and things, you know, other things that happen that are good, but it's all okay. So that's something that many people have during their experience. And a lot of people are often skeptical to, you know, psychedelics in general, or ketamine. You know, how can a single powerful experience have, you know, such long-standing changes, positive changes on your nervous system, and with severe mental health disorders? But we know that this is the case in the opposite, like with PTSD. So people, you know, you watch somebody get murdered. It's not even a physical thing that happened to you. You just saw it. It's an experience that you had. And many people have long-term changes in their central and autonomic nervous systems, sometimes for the rest of their life. And so, you know, the guys at the Johns Hopkins Center working with psilocybin called this inverse PTSD, that you have powerful, positive, transformative experiences that change your nervous system for the long term. And I'll give just an example of, I mean, I've got hundreds of examples like this, but one of the first patients I saw came to me. He told me later that he actually had in his pocket, he had a rope when the first time he came for a treatment, and he was going to hang himself if it didn't work. He had tried to kill himself many times before, and during his first experience, he described that he's slowly kind of dissolved into billions of atoms and sort of became this all these spots, molecules, atoms into the universe. And then he was floating in space, and then he felt the entire universe reach its arms around him and give him a hug. And he had a hug from the universe, from every person in the world, from the entire planet, from the entire universe. And this was something he had suffered, all kinds of trauma. And he came out of that experience changed. And this is just right after the experience. So not only, you can argue some of that is some of the electrical networks that were reset or whatever mechanisms are there, but the neuroplasticity hasn't even had a chance to really get started. So the point being that these experiences are without a doubt very important for many people in this therapeutic process. So I will just really quickly go through the potential mechanisms. Of course, this is all being studied, but that we went through. So there's rapid antidepressant effects that, this is kind of an important part that for many people, and I would actually say most, the treatment of the addiction it's not, we can get anybody off a drug. It's easy. But ultimately, the treatment of the addiction isn't about the drug. It's about treating what they're missing that the drug is giving them, treating the trauma that they had, treating the depression that they're suffering from, treating the anxiety, the underlying anxiety that's driving them to something that they need to feel calm, to feel safe, to feel feelings of love that they didn't get. So that's a critical part of it. Neuroplasticity, increasing their resilience and decreasing their vulnerability for relapse, resetting these electrical networks that are dysfunctional and decrease negative reward. There may be some kind of reconsolidation of maladaptive reward memories. Many people describe with psychedelic experiences these sort of epiphanies where they're like, or sometimes it's not even an epiphany, it's just feeling like, well, I don't need that anymore. It's, whatever it was doing for me before, I don't need it anymore. Many of these, powerful transformative experiences and increased insights and thinking about things in a different way than they had before, decreasing that cognitive rigidity, and also augmenting psychotherapy. And this is an important thing. Ketamine, it sort of opens this what we call the neuroplastic window. So there's this metaphor. I think it was Robin Carhart Harris who said it first, but I don't actually recall the new snow on the mountain, where the psychedelics and ketamine kind of layer a new layer of fresh snow on the mountain. So you kind of have possibilities to go in different directions, to not be stuck in all those ski tracks that you've sort of developed over the years, whether it's maladaptive thinking, feeling, behavior. So that was what I wanted to say, and I thank you very much. And if anybody has any questions, I'd be happy to answer anything.
All right, thank you so much, Dr. Stewart, for an excellent and such an interesting talk. So we can either, people can put up their hands if they want to actually say out the question out loud, or we can also do just write them in the chat if you guys prefer that.
Okay, I can look at the chat. Maybe that's the easiest way to do it. So somebody said, is it just as generally useful to anyone apart from the effects tailored to diagnoses? If I understand the question right, most of the time when we have some kind of medicine that we say it's good for this, it's good for that, it cures your bunion, it cures your rash, most of the time that's total bullshit. But the interesting thing about ketamine is that, and other psychedelics for that matter, is that they appear to be very transdiagnostic. So it really doesn't, like the effects that we see are actually very similar, whether you have an anxiety disorder, a substance use disorder, depression, bipolar depression. And it makes sense from a mechanistic perspective, which is that, so one, the DSM is kind of bullshit. It's based on symptoms. So it's sort of a constellation of different things. It's like in the old days when we said people have a fever. Well, what is that? They don't have a fever. Yeah, a fever is a symptom of the fact that you have a bacterial infection, and that's the problem. But a fever is just a symptom. And so, there's so many overlap. So we take these constellations of symptoms and put them together and say that's major depressive disorder or generalized anxiety disorder. And one of the fundamentals that people have is, of all these disorders have, is chronic stress pathology. So it's just a chronic stress state over a significant amount of time, or at a short period of time, but at a vulnerable period in your brain development, in the setting of genetics and a certain threshold to be at risk for something. So it appears that ketamine is sort of approaching it sort of therapeutically from, towards this chronic stress pathology. And also the meaningful experiences that people can have are quite relevant to a lot of different disorders. Let's see.
I think maybe next up was Lena Christine, who raised her hand.
Yeah.
Yes, cool, thanks. Yeah, very cool lecture indeed. Actually, I have two questions, and then I don't know which one to start with. Maybe I will start with what do you think, or do you think that the preparation and the integration phase also has an important part to play, or yeah, do you also include a preparation and integration phase in these trials?
Yeah, absolutely. Thanks for bringing that up. I just didn't have really time to go into that, but so yes, 100%. Ketamine was kind of weird because because it came from the medical model first. So all the other psychedelics have been kind of studied with this psychedelic container of preparation, set and setting, integration. So nobody would ever think of even doing MDMA or psilocybin in a clinical setting without those factors being involved. But ketamine was, was an anesthetic. So people just used it as an anesthetic with really just calling the psychedelic effects side effects, and not effects of the medicine, but side effects, and with complete disregard for the experience. So, and I admit, as an emergency physician, I've given thousands of people ketamine in the ER. They just got shot in the belly, and then I just give them a shot of ketamine, and they're just sitting there, and there's lights, and there's nurses, and everybody's screaming, and they're tripping balls, like in pain, freaking out, probably having the worst experience of their entire life. And that, you know, without setting, and there certainly was no preparation or integration there. And so the first time I actually did it in the clinic in the US, when the doctors gave each other ketamine, I was humbled to the billionth degree, and sort of realized, oh my God, what have I been doing for so many years? Just, you know, giving people this medicine without really giving it the attention it deserves. So yes, 100%. So in my clinics, we do preparation. So there's careful screening. There's preparation with the psychologist. The psychologist is present the entire time throughout the process. So it's the same person with continuity throughout, with a good therapeutic alliance. And that's, unfortunately, there's very few places that do that. Plenty in the US, but not elsewhere. And then integration afterwards. The actual experience itself is that, because of the dosing, is pretty psychedelic, where it's an internal experience with a blanket and eye shades and music. Sometimes they need some interaction support, verbal support, or a holding hand, but mostly it's an internal experience, and the psychotherapy happens afterwards. Yeah.
Thanks.
I can dig up some of the previous. I saw there were some questions about ketamine, both for bipolar and for sugar addiction. If you know anything about either of those.
Yeah, I could say bipolar. Yeah, we use ketamine for bipolar depression all the time. Bipolar 1, bipolar 2, it's just as effective. There's people with bipolar 1 need to be on mood stabilizers, because ketamine doesn't treat mania, it treats depression. But it doesn't increase the frequency of severity of manic episodes. As far as sugar addiction, it's a good question, because we're actually, Awaken is doing a trial right now on behavioral addictions. So, although I guess, I don't know if you call that that's not a behavioral, that is a kind of a drug, sugar, I suppose. It's a molecule. But we are doing, I think they're going to include people with overeating or, you know, sort of eating addictions in that trial, but it'll be gambling, sex addiction, video game addiction, which is exciting. That'll be, you know, it'll be the first drug, as far as I understand, the first drug trial for a behavioral addiction.
There's also a question about which institutions are treating alcoholism with ketamine currently in Norway or Germany.
Me. So yeah, Awaken clinics. We have a clinic in Oslo. March 1st, we're opening a clinic in Trondheim. I don't, you know, there's several other private clinics. Not as far as I know, they haven't expanded to that indication. There's a lot of public addiction treatment centers that are interested. I've given a lot of lectures all over, actually in Bergen, Haugesund, yeah, there are places, the Blue Cross near Oslo and Sykehuset Østfold, they're interested in using ketamine for alcohol addiction. So it is going to come, if but right now, as I understand, Awaken is the only clinic in Europe for using it to treat addiction.
I see there's a few more questions. Do you have time for
Yeah,
more or so?
absolutely, yeah.
There's a question about what's your take on treating chronic pain with psychedelics?
I think it's a great idea. Absolutely. Chronic pain is really difficult. It's really difficult to treat. There's so many different types of pain. There's so many different types of chronic pain. It really, the outcomes and the particular treatments used really depend on what type of pain it is, how long it's been going. But one thing that's relevant to psychedelics in general, so I mean, classic psychedelics and ketamine are analgesic, so they decrease pain. So acutely, there is decreased pain from these drugs. But in terms of sort of like, that's treating acute pain, but long-term chronic pain. So ketamine has this thing where it can reset the nerves that are in the spinal cord. There's something called central sensitization, where you kind of, it's like, when you got a mic and all of a sudden it gets this feedback loop and it's like, so people get that in their nerves. So you have these feedback loops where it's just, it keeps going even though there's not any stimulation of that nerve. And ketamine can reset that. So it has been used successfully for chronic pain, particularly neuropathic pain. But it's very complex, and it take a while to talk about it. But there's essentially two parts of pain in your brain. There's like the input, the component that your body is telling your brain, my finger is burning. There's that part of it. And then, so that's the signal. And then there's the affective component to your pain, which is your suffering, how much that signal is causing you grief. And that's something that part of it is something that can really be helped by psychedelics and ketamine. Because it's sort of like, that part of it is, if you have really bad back pain and you can barely, you're like, oh, I can't even concentrate because my back hurts so bad. And then some robber breaks in your house with a gun, you jump up and you run out. And in those moments of running, there is no back pain. Your focus, your attention shifts to something else. So psychedelics have the ability to sort of, one, kind of get you in a more mindful state of awareness, where you can kind of shift your awareness, sort of let the signal be there, but you're not suffering from it, if that makes sense. And it's a lot more complex than that. But yes, psychedelics can definitely, and they're being studied for pain a lot right now.
There's a question about the typical procedure of someone being approved into ketamine treatment. Someone who has a patient with borderline and is asking if she would be able to attend the integration and help with that.
Yeah. Yes. So there's actually very few like absolute contraindications to ketamine treatment. It's one of the safest drugs that exists. The doses that we give it's like 1/8 of the dose that I'd give a 4-year-old in the ER. And we use it on kids because it's so safe. That being said, there certainly are some people that wouldn't be good candidates. We generally don't take people with active psychotic disorders, and there's some medical conditions. What we do is an evaluation with myself or a psychiatrist, and you spend an hour and a half with them, get all their medical records, go through everything to really make sure that they're a good candidate for the treatment. Borderline personality disorder in particular, there's nothing dangerous about treating somebody with ketamine, so it can't hurt. But it kind of depends if that's their main problem, or is it sort of borderline, but they also have, this severe depression that could be helped by the ketamine. But at this point, there's some indication. There was a study at Yale that showed that maybe there's some borderline traits that can improve, symptoms can improve with ketamine. But it's a little unclear for right now. So no, it wouldn't be an absolute contraindication, but they would need to be assessed and figured out. And yes, we always involve people's psychologists, and if they want to come and be in some of the sessions, if the person wants that, they can do that.
See, there's a question on if you have any experience or thoughts on ketamine-assisted therapy for patients in LAR, also using methadone or levometadone for opiate addiction.
Yeah. No problem at all. Yeah, no problem at all. Norway has this weird concept that, like, if somebody's on drugs, then we can't treat their mental health problem. If somebody has a mental health problem, then we can't treat their addiction. It's, people get kicked out of their, psychiatrist because they smoked a joint or something. It's very disruptive, and it's not helpful. It's not helping anybody to separate these. We are humans. There is no, separation between our mind and our body, and so this but to shortly answer the question, there's no problem if people are on opiates, whether it's substitution therapy or there's evidence that it can really help opiate addiction. So no, that's not a contraindication. It'd be interesting to know if, maybe the LAR would have problems, and they'd think it, try to kick the patient off LAR if they came to a clinic. But I don't think so. As long as there's good collaboration, and it's a medical treatment,
There's a question about risk as well. What risks are involved when doing this therapy?
Yeah, excellent question. And I didn't have time to go through that, but to be short, as I said, ketamine is one of the safest medicines that exists. It's literally, its side effect profile is safer than paracetamol. You can give 100 times the dose to somebody, and they just sleep for a couple hours and wake up. And particularly at the doses that we're using, it's incredibly safe. The risks are, it increases your heart rate and your blood pressure a little bit. It's got some sympathomimetic effect. Is about the same as if you walk up the stairs. So if you exercise or can walk up a couple flights of stairs, then your heart can tolerate ketamine. So that's why we exclude people with severe heart disease or heart failure. People get dizziness, a little bit of nausea and vomiting sometimes if they're really dizzy after the experience, mild headache. So those are kind of the medical issues that happen. There's other sort of risks of long-term ketamine use that we don't see clinically. Those are, if you take ketamine every day, recreationally, there's a lot of other problems that can happen, but we don't see those in this setting. I think the primary risk is, it's a powerful experience. So it can't hurt you. So it's just, like a dreamlike experience. There's nothing that can really hurt you there, but it could be really scary. People can have panic attacks. You could have a really challenging existential experience where you feel like you died and you don't know if you're coming back, and you lost sense of time, and you think you exist in this space, and that can be really scary. But everybody comes back from it. So 100%, people don't get, you're not going to get a new psychotic disorder. All the any kind of anxiety or distress that you have during it resolves over the course of a couple hours at most. But that's why you need preparation, why you need good integration, that the psychotherapist is there with you to support you if it's really scary. Many people with trauma, sexual trauma, that stuff will come up during the experience. And it's actually really good that it happens, because it can be very therapeutic, but it can be really intense. People can be more vulnerable and kind of shaken after these experiences. I had a case, a woman who was sexually abused by her father for like a decade, and one of those experiences came up, and she experienced that during the process, and it ended up being really therapeutic. And she says today that she's alive because of this treatment, but it was really, really hard, and it's something that you need to put in a therapeutic container. So I would say that's a risk of doing it in a poor way. If people that, there's clinics that you can go to, and they'll just, give you a shot of ketamine, and maybe there's some nurse, but, there's a student hanging out in the room reading a book or something, and somebody that's not trained in psychedelic assisted therapy. People can have bad outcomes from those types of experiences. Yeah.
See, we have 5 or 6 more questions. If you are starting to get low on time, you can choose them yourself, so I can just continue reading.
You can go ahead. Yeah.
Okay. So there's a question about what are your thoughts about using music in ketamine therapy?
So my clinical experience is that it's really important, and we also have some research from the psilocybin research that supports that it's actually linked to more therapeutic effects. So having music versus not having music. Beyond that, we don't know. We really. It's better to have some music. We don't really know what type of music. It's incredibly individual. We generally, having a powerful experience without a psychedelic, without the music, it can be a little bit like floating in space without a, line to the space station. And so like the music, it can give it some structure, some this sort of sense of, some kind of structure in this other dimension, and can hold it a little bit with a pattern. So it has incredible effects. It's very, it can totally change the experience, but there's so many variables, we don't really know a lot about it. But for most people, you really have to be an experienced psychonaut to have an incredibly powerful experience, deep psychedelic experience without some kind of music there as structure. So when there's complete silence, it can be sometimes overwhelming or distressing, but some people like it. But that's an area of study. Music is super interesting.
There's a question about if any patient or client can choose this treatment if they want to. or if they have to have a specific diagnosis?
Yeah, so in the US, it's pretty Wild West. I mean, you can say, I want to explore my consciousness, and you could get the ketamine treatment. In Norway, so the rules here is that it has to be faglig forsvarlig, academically defensible. So the drug is legal. I, as a doctor, I can give any patient ketamine if I decide to do that. That being said, when you use it for anything other than anesthesia, any other indication, that's utenfor godkjent indication, off-label use. And the rules around off-label use, that has to be faglig forsvarlig. And that's sort of a gray area. And what it really means is that the reason it's a gray area is it's up to a doctor to decide, is the risk of this medicine outweighed by the potential benefits for this particular person. So, that's why when we have somebody has cancer and they're going to die, we'll give all kinds of medicines that were not approved for that. And they make they cause all these other problems and super dangerous, but the risk benefit is good for that person. And so it's similar with ketamine. So currently we treat a pretty wide range of mental health disorders, so depression, anxiety disorders, OCD, eating disorders, and addiction, and PTSD. But it really depends on the particular person whether they would be a good candidate. So, it has to be defensible. So, if somebody has a diagnosis, so it's clear what the problem is, and that they've tried a couple things for it. It's not like the first thing they tried. They've maybe done some psychotherapy, maybe they've tried an antidepressant or something else, and they didn't work, or they had a lot of side effects, then that risk-benefit ratio is appropriate for that patient. So it's an individual assessment, but so it's not exactly everybody who wants to, but everybody who has a problem, who has at least tried some other standard things first, it could potentially be something for them.
Next question is about if you know any qualitative research on perspective change after treatment. For example, that the cosmic hugs feels a bit more attainable, or on this observer state, something about this.
There is, yes, there is qualitative research. It's pretty thin. So, most of the research on ketamine particularly has been kind of clinical research. There is some stuff out there, but it's an incredibly rich area to explore. I mean, the phenomenology of the ketamine experience is totally wild, and it's so variable. It's variable within patients, the same person, same dose, same music, next time, totally different experience. Sometimes it's what I call intravenous meditation. You're just floating in space and there's nothing but consciousness. And other times it's incredibly vivid forms and meaningful narratives and things that happen. And it's a very rich area to explore. And in terms of, particularly in that question, like perspectives and insights and changes in traits and behavior, very, very cool. So you guys should all do research on that, definitely. And I'd be happy to participate.
Sorry to intrude, but we may lose the stream at 8:30. So we may have one question left, perhaps, or if we can get to maybe before the 8:30 mark. So
looks like there's only 2 left.
okay.
So the next is, have you seen people becoming psychologically addicted to ketamine after this treatment?
No, I haven't personally. So I've been doing this for about 7 years. I have not seen that. You know, what you see, and you know, we've been doing this for a long time in the US, and there are hundreds of thousands of people that are getting ketamine treatments there. You don't, so the thing is that, so first of all, many doctors will think, oh, you know, it's like it's a ruse, you know, they go there and they have this super euphoric experience, and then they, you know, they're going to want to go back and get ketamine. I mean, I was interviewed for this article in the New York Times where a psychiatrist said, so I was arguing that everybody who goes to an ER with suicidal ideation should get a shot of ketamine. And because it has this powerful anti-suicidal effect. And the psychiatrist said, well, you know, people are going to start going to psychiatric hospitals and saying that they're suicidal just to get a shot of ketamine. And it's like totally insane. Yeah, that's totally insane. But the point is that, so a lot of drugs, you know, they take you up or they take you down, you know, opiates, benzos, barbiturates, alcohol. But ketamine is not always euphoric. Sometimes it's amazing. Other times it's just really weird. Other times it's anxiety producing. I mean, it's a psychedelic, which is mind manifesting, this sort of non-specific amplifier that could amplify a lot of stuff that isn't necessarily just euphoric. So you know, that's why the classic psychedelics are not considered to be addictive, and ketamine has a very low addiction liability. Certainly there are people that do it, but the people that come to have, you know, their depression treated or addiction, it's not, yeah, we just don't see that. So there's a couple case reports in the US, but it's like where it's more a problem because of the system. So, you know, they can't afford the treatment, so they get it on the street. And then when they get it on the street, they are not taking it at the frequency that you should be doing it. They're doing it more frequent, and then start taking it a little more frequently, and because you get a tolerance. So yeah, I haven't seen it, but it probably happens rarely.
I see that Lena has raised her hand.
It's true. Okay, so as you were talking about trauma, and I was just wondering if ketamine has the potential, for instance, with utviklingstraumer, like relational traumas, if the ketamine has the potential to kind of unlock memories that are suppressed.
Yeah, so I guess 2 parts of the question. I mean, yes, it has potential with all different types of trauma. You know, I've seen, you know, incredible, you know, people have these, you know, powerful experiences of reconnecting with people they've lost, sort of, you know, coming to, you know, working through very difficult relationships in their childhood, things that happen during the experience that can be really transformative. In terms of, yeah, memories that are subconscious, or that's hard to know, because it's hard to know what is, you know, it's a hard thing about psychedelics is what, you know, what is, you know, what has like sort of real information, and what is just a strange, wild, interdimensional blob. And So it's a bit complex, and yeah, a lot of stuff bubbles up from the subconscious, but what do you do with that? How do you use it? How do you make sense of it? What parts of it are worth listening to? What parts of it are just bizarre? And yeah, it's a big, complex topic.
Definitely.
I can say if anybody has other questions, you can just email me. I don't know if it was my email on the link or anything or no. Anyways, yeah, I'm sure people can find my email. So
I can always add it to the event link. So
yeah, sure.
if anyone wants to go back to the discussion and answer some questions or ask some questions there, yeah, we'll be able to connect you.
Great. Thank you very much.
Thank you very much, Dr. Stewart. Thank you so much for giving us your time. Thank you everyone for attending. And we also will have another NPV talk February 23rd. So be sure to check out our events to get more information. Thank you so much and have a wonderful evening. See you very soon.
Good night. Bye.
Good night. Thank you all. Bye-bye.